urolithiasis, either in the kidneys or ureter or in the bladder or in urethral stones. So it's not a new disease. It has been seen in the Egyptian mummies. So it's a very old disease, but still it's present. And in America only, it causes around 2.1 billion work, and a very common disease in the West as well. So around most of the emergency department which they deal with is renal colic. The renal colic with acute pain in the patient presence in the emergency are most common, one of the most common cause of emergency diseases. So it's almost seen in most of the part of the world, but in Asia it's around 2 to 5%, and in the West it's around 8 to 15, and in the Arabian countries it's most common, around 20%. So the lower economical status, there are high chances of having these stones. The most of the age where it is common is around 20 to 49 years, and in the male to female ratio, it's around 3 to 1. A little bit about the stone formation, just for your basic concept, that when in the urine you have some elements that are parsed or that which are excreted in the urine. So among them, if it is unsaturated of those elements or those ions, like for example calcium or oxalate, so it will not cause formation of the stones at all. But when there will be a supersaturation, still that at that time there will not be a production of these stones or crystals until there is the limit achieved where you cannot have any further saturation. You cannot go beyond that saturation. That's called as formation product, when the stone formation or crystal formation starts, and then the nucleus forms and the stone formation starts. Well, you must be familiar of these few of these stones. The most common are the calcium oxalate stones, which are radio-opaque. So make it very clear what is radio-opaque and radiolucent. Those stones which can be seen on simple X-rays are radio-opaque, and those which cannot be seen on the simple X-rays are radiolucent stones. So calcium oxalate, calcium phosphate stones are mostly radio-opaque, which can easily be seen. And the uric acid and ammonium urate are the radiolucent stones, which cannot be seen on X-rays at all. And there are a few poor radio opacity stones. Among them, there are two common magnesium ammonium phosphate, which is also called as struvoid stones, and the cystine stones. I will not go in details of etiology, but there are either non-infection stones, which are commonly idiopathic stones, calcium oxalate stones, or there are infection stones because of the infections, genetic stones because of any genetic diseases. Among them, the cystine is the common one. This is the most common thing that is usually asked in your questions, that what is the clinical risk factors which causes stone formation? Either family history, the diet, the water intake, the hydration status of the patient, the kind of work the patient is doing, and what kind of occupation he is going through, or the small bowel diseases. Among them, the IBD is one of the common, and the medical conditions causing hypercalciuria, or the medical conditions which cause aciduria. These all, because alkaline urine, there are low chances of making stones, and with acidic urine, there are high chances of stone production. Well, we'll discuss 4 types of stones here, because these are the commonest stones which are seen: the calcium stones, and the struvoid stones, uric acid stones, and the cystine stones. The most bulk of the stones is calcium stones. That comprises of 75% of the stones seen, and these are the most radio-opaque stones seen. And there are multiple risk factors or multiple etiological factors that you cannot go through everyone, but the most common one is a poor hydration, which leads to the stone formation. So you can easily address both of the stones here. Here on the simple X-rays, this is because this is a radio-opaque stone, so you can easily see this stone on the X-rays. And here on the CT scan, you can also address the same stone in the lower pole. See, with the stones which are radiolucent or which cannot be seen on X-rays, they can easily be seen on the CT scan, because on CT scan, the radio frequency is the one which opacifies or hyperdense the stone in the CT scan, so we can easily see all of those stones in the CT scan. The other type of stone that is second number common is 15%. That's infected stone. It's called as infected stone, or it's called as true stone, and it's staghorn. It's also called as staghorn stone because you can see the shape of the stone. It's usually a staghorn type of stone, which is going inside every calycis. Right, and usually these are asymptomatic stones, does not cause pain, but this is all because of these infection, and it's completely opacifies the whole of the calicial system of the kidneys. Most common organism is gram-negative, which causes it, and the reason is pH as well, and it's commonly seen in females because UTI is common in females, so the stone, infected stone, is also common in females. Here you can see again the stone, which opacifies all of the calyces and the pelvis of the kidney. So it grows very slowly, but does not cause pain. So the simple thing that patient comes with is UTI, recurrent UTI. Other stone is uric acid stones. It is comprised of 6% of the all renal stones, and this is also one of the radiolucent stones. As around and the pH is, when it's less than 5.5, it leads to the stone formation. And along with that, there is patients who are with gout. They also have high chances of uric acid stones because there is hyperuricemia in those patients. You can address here that with uric acid stones, this is an X-ray of the patient of the uric acid stone, and you cannot see any of these stone on the ureteric line. And here you can see this is IVP done in intravenous pylography X-ray. Here you can see the kidney is hydronephrotic. There's stasis of the dye inside the calyceal system, and there is some small radiolucent area where the dye is not passing easily. It's this because of the stone, but you cannot see the stone clearly here. But the same patient over here on the right side is a ureteric stone, which can be easily seen on the CT scan. So the radiolucent stones, which cannot be picked up on the X-rays, can easily be picked up on CT scans. Cystine stone is one of the least common, but still important stone, which is comprised of 2% of the all renal calculi. It is genetic because of the genetic diseases, which is autosomal recessive trait. It's a radio opaque, but it's partial radio opaque, or you can see partial radio faint kind of stone. And these are seen on X-rays, but difficult to find it. Here you can see this is a kidney shadow, and among them this is the radio opacity, which is not very clear. So it's partially radio opacified. So the cystine stones, as I said, it is a partial radio opaque stones, which can be seen, but with a good eye. So how does patient present? The most common thing should be remembered. There will be pain if there is obstruction. If there's no obstruction in the renal stone, if there's a small stone or bigger stone, or there is a true stone, they do not cause pain until and unless there is complete obstruction. So the asymptomatic stones are there in the renal stones, the kidney stones. But when the stones are obstructing or they are in the ureters, they cause severe pain. And the other thing is they will lead to the infections. They can cause hematuria. Either it is microscopic hematuria or the macroscopic hematuria. Both of them can occur. And there can be silent stones. Silent stones are one which does not cause pain or does not cause any symptoms. On incidental finding, if you go for ultrasound for any reason, and you can find out there is a stone in the kidney. So these are actually not causing any pain, no any symptoms, because they are small stones and present in one of the calyceal system and does not cause any obstruction. That's why there's no pain, no symptoms at all. But when there is obstruction, it causes severe colic. Here you can see on the X-rays, there's a proximal ureteric stone causing proximal hydronephrosis, dilatation of the calyceal system, and when there's obstruction, Subsequent acute obstruction, as you can see, the proximal vein dilatation and uterine spasm. What it causes? It causes acute renal colic, which is very painful and very difficult to be beared. What other thing can appear? The classic renal colic appears with three main symptoms. There will be a severe flank pain, which most likely be radiating towards the groin, but it's not necessary. And the other thing will be there will be hematuria, either it can be microscopic or macroscopic or gross hematuria. Nausea or vomiting can be there, but not every time. But yes, this can be associated with the renal colic. Coming to the staghorn stone, as we said, it is an asymptomatic stone, except they will be leading to the recurrent infections. These are branch stones and opacifies the whole of the kidney pelvic calyceal system. Okay, if there is bilateral obstruction of the kidneys because of the stone, and there's bilateral hydronephrosis, and there's complete obstruction, what happens? The urine cannot trickle down from the ureter, and there's complete obstruction. And this can lead to the post-renal azotemia, which can lead to the acute renal failure, and the creatinine will jump. And this can also happen when there is a patient who has solitary kidney, single kidney, and one of the stone is causing obstruction in that one kidney, which is actually working with the patient. So it can lead to the acute renal failure. Or we also call this acute renal failure as obstructive nephropathy, right? So now the character of the stone pain depends on the level of obstruction where it is obstructing. Either it's in the pelvis, in the pelvic ring, or ureterovesical junction. There are three parts of the ureter. The upper ureter, it causes pain in the flank area and the lumbar areas, which radiates around into the anterior abdomen, but does not go beyond that level. Okay, if there is a mid-ureteric stone, then the pain will be causing, same severe pain will be there, which will be radiating down up to the inguinal area or in the iliac area, and it usually mimics with the appendicitis on the right side, and on the left side it mimics to the diverticulitis. And you must be knowing, or you must have read about appendicitis. You can easily differentiate both of them, as stone can cause fever, but there will be severe pain which will be coming from the flank area down to the iliac, associated with vomiting, and there will be macroscopic or macroscopic hematuria along with that. There are other signs of appendicitis which will be absent here. Coming towards the distal stone or UVJ stones, uretrovesical junction stones, it can cause bladder irritation, and which leads to the urinary frequency, increased number of urination, and dysuria, painful maturation, which usually is not with the ureteric stone, but because of the irritating quality of these stones down there can lead these symptoms. And the distal ureteric stones, they can have pain going down up to the genitalia. So this is the broad distribution of the pain. Okay, the bladder stones. Bladder stones are usually asymptomatic until unless there is small stone which comes in front of the urethra and causes complete obstruction of the urine and leads to the urinary retention, which is one of the commonest symptom and the emergency symptom which can appear. Patient has to rush towards a hospital emergency for acute urinary retention for that. The other thing is that it can cause the UTI as well, bladder infections. This is tied to this. Okay, coming to the diagnosis. About diagnosis, the confirmatory tests are all are imaging tests, not the blood test. And the symptoms are the main thing that actually confirms us that what kind of symptom he or she is having, and there are high chances of having the nephrolithiasis. So we go for urine DR or urine depth stick test, along with that creatinine. This is a basic blood test that we go for. Coming towards the imaging test, okay, the Basic test, imaging test is usually ultrasound. For any renal or urogenital system diseases, we go for ultrasound every time. But when a patient appears to you in the emergency department and with basic uh, three symptoms of acute renal colic, you can jump directly towards CT scan and go for CT scan rather than going for ultrasound, because ultrasound can sometimes cannot pick ureteric stone, but CT scan can easily pick the stone in the uterus. So you can jump towards CT scan. CT KUB is called, or CT pyelogram it is called. So you can jump directly to the CT scan in those patients. Ultrasonography is the basic test usually done. They can pick up the renal stone easily, and they can tell you about the hydronephrosis or hydroureter, the dilatation of the renal pelvis or the ureter, and they can miss around 30% of the stones which are present in the ureter. So plain radiograph or X-ray KUB can also be done, but this can also miss around 40% of the stones, of those stones which are radiolucent. And there are other things that can mimic, or they can be there are other differential diagnoses of those ureteric stones on X-ray KUB, like phlebolith can be there, or it can be lymph calcification or lymph node calcification. So there are other reasons as well. So you cannot have a confirmatory result on X-ray KUB. Still, if there is in the X-ray KUB you have doubt, you will have to go for CT scan to confirm your test. How do we manage the patient? So that's the main thing. And in the management, there are two things. There are, first thing, a patient with acute pain, acute symptoms, you have to treat those symptoms and those difficult time of that patient. And once that difficult time or emergency has been treated, you have to go for the definitive management, that is surgical management, or that can be medical expulsive therapy along with that. So initially what we do is we give fluids, we give analgesics, IV analgesics, we give antiemetic, because patient can have things along with that. And if the patient is having infection, if he or she is having fever, then definitely he or she is having infection along with that. So you send urine culture, you send blood culture, and you start broad spectrum antibiotics straight away. What are the problems that usually occurs along with stone? There is sometimes patient present with you with acute renal colic, but he has come to you a little late and developed a pyelonephritis or pyelonephrosis along with that. So pyelonephritis is the renal infection. Only pyelonephrosis is when there is abscess formation inside the renal pelvic axial system. Or the third and the most severe thing is when these are not treated at its prompt time, it can easily lead to the urosepsis. And when there is sepsis, you need a monitoring system and to enter the patient inside the hospital. So it's whenever there is renal colic, start treatment straight away. Do not wait, or do not let him go on just simple medications, because these can sometimes lead to these disastrous symptoms or more comorbidities. So when you decide for the spontaneous passage of the stone, that if the stone can actually pass down, so this is especially for ureteric stones. So you think about the size of the stone. If it is less than 4 mm stone, there are high chances, 80% chances that stone will spill down. And if it is more than 8 mm stone, there are very less chances that a stone can spill down, because it's hard that stone can travel down in the ureter and go beyond from the UV junction. So when you do a hospital admission, you start with oral analgesics. If it is like in the hospital, when you need a patient to be admitted in the hospital when the oral medications is not working and the patient is having severe pain, and which is only treatable with IV analgesics, vomiting which is not settling down, or patient has started or developed UTI. If the patient has a fever and you are suspecting that he can have pyelonephritis or pyelonephrosis associated with the ureteric stone or renal stone, then you cannot let him go home. You have to admit the patient and start with the broad spectrum antibiotics and do the basics, because you cannot leave a patient with a compressed or closed kidney with this kind of infection, because if you do not decompress or give any way to excrete the urine from the kidney, it can easily move on to sepsis. Within 24 to 48 hours, a patient with a pyelonephrosis or pyelonephritis can develop sepsis. So this is an emergency that you need to admit the patient and start with the broad spectrum antibiotics and decompress the kidney in any way. We will discuss how we decompress the kidney. So when the admission criteria, you go for admissions. So okay. In the aortic stone, when the patient is very asymptomatic or having very less symptoms, small pain, and which is easily coverable with the simple oral analgesics, then you can ask him that you can wait and go for medical expulsive therapy, MET, that we will give you some medications and you might pass the stone by yourself and you might not need any surgical procedure to be done. In that scenario, you do not get the patient admitted down, or for the spontaneous passage as well. But when you need, when these procedures, you need an admission, and that comprises semi-rigid uteroscopy and lithoblast for the small distal stones, and the flexible uteroscopy with laser lithoblast when there are large stones or there are proximal stones. So what is medical expulsive therapy, MET? You give some NSAIDs and oral opioid analgesics at some time, but usually NSAIDs are better to be given, and alpha blockers are usually given, either tamsulosin or alfuzosin. What it does is it broadens the distal ureter and causes the expulsion of the stone from the distal ureter. So it's for the stones 5 to 8 mm in size often pass with this medication, but if it is more than size of 8 mm, do not offer MET, because patient will be bearing the pain and there are very less chances that patient will actually spill the stone out. So what are the contraindications to be for the medical expulsive therapy? It's stones if it is more than 1 centimeter at any location in the ureter, or if it is more than 6.6 centimeter in the distal ureter, or there are bilateral ureteric stones, or there is solitary kidney, or there is associated symptomatic UTI. In all of these conditions, you cannot give medical expulsive therapy, though you will need to give him offer to get admitted and get your surgical procedure done. So if you're giving MET, medical expulsive therapy, then you have to wait for 4 weeks, because within that time, if the stone spills down and passes spontaneously, then that's fine. But if the stone is not passing and 4 weeks are passed, it's better to go for some intervention, some surgical procedure, because if you let him move on with this, this can cause severe hydronephrosis in the kidney and causes nephropathy. So that's why it's recommended do not wait more than 4 weeks. So for proximal ureteric stones here, for more than 10 mm, more than 1 centimeter stones, you go for either URS or you can go for ESWL. And if it is less than 10 mm stone, 1 centimeter, you can also go for URS and ESWL. Both options are open for that. In distal stones, URS is the one which should be done in most of the cases. But if there's a small stone, you can go for both options. Usually, the common procedure which is done is Baker procedure, it's URS, because it's a single time procedure done. With ESWL, you need multiple sessions to go for. Here you can see the uteroscopes. There are two kinds of uteroscopes which are entered from the urethra down to bladder and then into the ureters. This is a straight semi-rigid ureter which cannot deviate from front. So it is done. It works in the distal ureter and proximal ureters, but it cannot go into the renal pelvis or in the renal chiastic system. But this is the flexible ureteroscope, which can work on the ureters, and also it can work inside the pelvis, renal pelvis, or even one of the chiastic system, because it can easily move from the front and into the multiple chiastic systems. So Surgical options, once the obstruction is relieved, either any of the formation, we will discuss these stenting or percutaneous nephrostomy. As we discussed that if patient comes with a UTI or a pyonephrosis, you will not go for definitive surgery straight away, but you will perform another procedure that's to relieve this obstruction. And these two or one of them. And then you will go for the definitive procedure, either ESWL, ureteroscopy, PCN, percutaneous nephrolithotomy, or the open surgery, which is now rarely used, but still this is an option. So when there's obstruction and infection in the collecting system, you need to divert, you need decompression of the kidney, you need to take out the urine in some other way. So you need either percutaneous nephrostomy or ureteral stents. So this is the percutaneous nephrostomy, in which you pass a small tube inside the kidney to divert the urine output directly into the bag from the back of the patient. The other one is ureteral stents, which are passed from the ureter. It is a stent which is placed between the bladder and the kidneys, and it actually bypasses stone obstruction. So once you have performed those procedures and there's decompression done, or patient is not having any UTI or infections or any risks, then you can easily move on with the ESWL, extracorporeal shockwave lithotripsy, which are of three types: electrohydraulic, electromagnetic, or piezoelectrical source. You can go for percutaneous nephrolithotomy. These are done for the renal stones which are more than 2 centimeter size inside the kidney, or there are Staghorn stones or like those. Here you can see this is the puncture done in the back of the patient, and the percutaneous tube has been placed inside the kidney, and you are working on the stone. This is a flexible ureteroscope which goes up to the kidney, as I told you before, which can deviate down inside the kidney and break the stone with a laser jet. And you can perform small stones can be performed with RIRS, which is retrograde intrarenal scopy. So in the renal stones, what do you have options? If the stone is more than 2 centimeter, percutaneous nephrolithotomy is the best option. Other than that, you can go for RIRS or ESWL. But when it is around 1 to 2 centimeter, ESWL or endourology is RIRS same, so it can be done. If it is less than 10 mm stones, there's ESWL or RIRS, again there are options. But main thing is when it's more than 2 centimeter of size, PCNL is the best option for those patients. So in some cases, you need combination. You do percutaneous nephrolithotomy and then do some ESWL as well, because this is a multiple calyceal system stone present. So sometimes you need some extra procedure to be done along with that. These are the open surgeries which are not now done, but you should remember the names because you can be asked in your exams. It's nephrotomy, endotrophic nephrolithotomy, and pyelolithotomy. Pyelolithotomy is one when you are opening the renal pelvis and removing the stone from the renal pelvis. And endotrophic is when you open the kidney as a book and remove the stone from multiple calyces. And in the nephrotomy, it's like opening one calyces of the kidney from the back and removing the one stone from one of the calyceal system. So long-term monitoring is also done in the patients which are having recurrent stone formation, and you need some basic metabolic evaluation. You don't need to go in details, but yes, you need to know that some of the patients need metabolic evaluation of the stone formation to know the details, so they can be treated on medical things. So most common findings that actually causes is hypercalciuria, hyperuricosuria, or oxaluria, which needs to be treated medically. Tumor prophylaxis is done for the uric acid stones with allopurinol, and some medicines are given with the genetic diseases of cystine. For those patients, you need to give medicine because they will have recurrent stones again and again. Dietary measures are mandated to be told everyone that they should have excessive amount of water intake, so at least they have total urine output of more than 2 liters in 24 hours. Salt and protein should be taken in the less amount because these are the most common reasons causing every kind of stone.